no other organization has been able to break even in our science and research like Danone has. With this, I want to leave you with a question. Would you rather, as healthcare professionals, recommend an infant formula that is below the standard where the need arises, or will you rather give the one that is closest to breast milk?
We are in the third world, and in the third world, we have challenges. And that's part of what we came to discuss. Challenges of growth and immunity in infants in our practices. Before I continue, so that you won't say this man just suddenly grabbed the microphone and speaking. My name is Kayode Adeniono. I'm a pediatrician. I do endocrinology, I do nutrition in children, and I also do gastro. So I do metabolism too. And on the high table is my own dear Oga. I always say, if you were in the last meeting, I said it, that without him, I would not be in Asaba. He's our former MD, Dr. Leo Eronse. Is the moderator for the discussion session. Then the lady, I don't know what color is this. You know, ladies have, is it cockroach brown? Or onion purple? Whatsoever it is, she's a quintessential matron who knows her onions. Matron Ethel Obro. Coincidentally, the three of us, except one person that is not around here, were the pioneer members of the pediatric department when FMC started in the 90s. Yes. So, and here is Mr. Odo, is one of our very big chiefs in nutrition and dietetics in FMC Asaba. So, this is we are going to do some discussion later. We all came here. We are professionals in our own field. And in this place, you are recognized because you have contributed to child nutrition, growth, and development in one way or the other. So please clap for yourself. I would have loved that we quickly know each other. Because so that when I see you on the road, I will not say, hey, shh. So I think we'll start just your name and where you work.
My name is Charity Atuchuku. I work at FMC Asaba.
Okay. My name is Chidima Ibokwe, also working in FMC Asaba.
My name is Emma Augustina, working at Mother Teresa Specialist Hospital.
Osao Success. I work with Asaba Specialist Hospital.
Ashikode Boawele, Asaba Specialist Hospital.
Monye Edith, General Hospital Ogwashoku.
Solomon Okoro, FMC Asaba.
Igwe Buka, St. Joseph Hospital Asaba.
Umoibo Kenneth, I work with Asaba Specialist Hospital. So.
Emeka Abon, FMC Asaba.
Ezozo Chibike, St. Luke's Hospital Asaba.
Efele Stella, Oko General Hospital.
Okonkwo Joy, General Hospital Okwe.
Okere Adeze, FMC Asaba.
Obocha Ejiro, FMC Asaba.
Edugero say FMC Asaba.
Awana Roda from Police Medical Services Asaba.
Kole Rita, General Hospital of Washington.
Let's give ourselves a round of applause, please. So we are all welcome. We are going to go into, we are just trying to modify the program. We are going to go into the panel of discussion now. So I'm going to hand over to the moderator to just moderate the discussion.
Thank you, Dr. Adeniran, for at least taking us through the rigors of introduction. We have a purpose for coming here. Beyond Aptamil, beyond Danone, we are talking about infant feeding, nutrition, immunity, mental development, so on and so on and so on. So we here, we must have been chosen based on certain parameters best known to the organizers, but I'm sure each of us has some experience or experiences in infant nutrition. We are going to be talking about a child who has been born. We are not talking about the child that is in the mother's womb. I'm sure we don't have gynecologists here. Apologies. So we are talking purely about children that are born, and they are Nigerians. And we are talking about how do we cater for them? How do we ensure that they will be better than us tomorrow? Have better opportunities than us? And all that will start from what they eat from day one. They have been born. We couldn't do anything about that. Whatever happened in the womb, we have nothing to, we can't change that. But we can at least impact on them from day zero. That's why we are here. And impacting on them on day zero centers primarily on their nutrition. And when we are talking of nutrition, we know what we ought to do from day zero, first hour. In fact, now they say 0 hour. But as the child is coming out from the mother's womb, the child should launch on the breast. That should be the landing pad, and start doing what the child knows how best to do from that point on. And if we get it right, it is easy going. If we get it wrong, it is rough going forward. Particularly in today Nigeria, the options are difficult. The options are not cheap. The options are in dollars and euros. And we know that not many people out there have access to dollars and euros. And if you say, okay, convert it to naira, you know that it is. We are now beginning to talk of trillions. Before in Nigeria, when you are budgeting, you budget in millions and billions. But because our currency has improved, we are now budgeting in trillions. However, majority of Nigerians don't have that empowerment to budget in trillions. And so what do? We must come back to basics. We must come back to the one that we know we are capable of doing and doing very well. Infant nutrition starts from the breast. And we are going to be looking at that very critically. What are the advantages? What are the benefits of breastfeeding? And what are the disadvantages of not breastfeeding? It is when we have exhausted that, we will now nosedive into the era of technology. Okay, technology is what has given rise to the infant milk that we are talking about today. Infant milk, as you know, the manufacturers or the originators or the companies or the researchers, they are trying so hard to mimic breast milk. If it is not Panadol, if it is not Coca-Cola. So If it is not breast milk, it is not breast milk. So, but we will also take the advantages of that, because when things get tough, they say the tough gets going. So when it becomes almost near impossible to provide breast milk for this newborn child, we know that things are getting very tough and rough for the mother and for the child, and indeed for the family as a whole. And so something must be done as a rescue alternative so that these children will also attain their optima in life, in every aspect that you can think of. So we won't say because a mother cannot breastfeed, that child should be sentenced to early grave. No. Something must be done. And whatever can be done, either by individuals or by corporate organizations or by government at large, to assist such a child to survive, must be done, must be encouraged. And that is the reason why we are all here. We are going to start from the natural to the technological. On that note, I think I will invite the guru we know. Last time he spoke to us on infant nutrition under the same platform of Danone Nutricia. So we will ask him to recap for us some of the things that we discussed during that forum. On that note, I want to welcome all of you. It will not just end there from the high table. We'll come to the floor. So I invite Dr. Adeniran to take the floor.
Thank you, boss. Well, what we discussed, that was last day anyway, was on issues of probiotic and all those things. But today, we are actually going to be looking at infant growth and immunity. You know, how the nutrition impacts infant growth and immunity. Now, growth is what all of us somehow had passed through. And even though we are not growing, we are maintaining now. And one can say that growth is the physical changes that happens from conception through infancy and through childhood and into adolescence. By the time actually one gets into adolescence, your growth plate fuses and growth stops, but you begin to maintain. Now, in terms of immunity, immunity has to do with how we try to fight infections, to ensure that we keep alive. So these two phenomenon are actually intricately linked and can significantly influence several nutritional challenges. So in my own practice, what I see is what I'll try and relate to you. Now, don't forget that my Oga talked about the fact that there is a lot of money now, but there is a lot of scarcity in the midst of plenty. Unfortunately, don't let me say unfortunately. The reality is that what we learned in school about inflation, that says that a lot of money chasing what? Few goods. That is what we are seeing now. The monies are plenty. What they are able to do is very small. And consequently, we also know that when we look at social class or socioeconomic status, we discover that a lot of people have been pushed into multi-dimensional poverty in Nigeria. They're in hundreds of millions. What is the consequence to this? The consequence is that the children are the ones that are bearing the brunt. And after the children is the women. Now, just yesterday, I was seeing a patient. My senior registrar is here. And the mother was talking about her breast. She's not producing enough breast milk. And we are trying to encourage her to produce enough breast milk. And she said, oh, this is my small breast. Now, the truth about it is that the production of breast milk is not about the size of the breast. You understand it? It is actually about priming. It's about priming. And priming actually starts from when the woman is pregnant. And I was joking with them yesterday for some of our female colleagues here who have done the antenatal care in FMC. I usually joke that they come to eat my and somebody added that they also take soya bean milk to eat. So they end up eating my and soya bean and drinking soya bean, and they are not taught the depths and the breadth of breastfeeding. Now, the ability to initiate breastfeeding, robust breastfeeding, adequate breastfeeding starts from the mind of the woman. Don't let us forget that the hypothalamus is the one that actually controls what we call the master gland, which is the pituitary gland. And the pituitary gland now goes and secretes hormones that both help in the production of breast milk and also release of breast milk. So when your mind has not been made up from the time of conception, it becomes a bit very difficult for breastfeeding to be successful. So I'm talking about pre-conception, pre-delivery mode for women who want to successfully have lactation or to be able to breastfeed. Be that as it may, we have said this over and over again about the fact that breast milk is the best for the child. It's a natural food for the child. It is not expensive. Yes, we know that there is no free lunch even in Freetown, in Sierra Leone. But the truth about it is that, right from when the baby is in the womb, the baby is like a parasite. No matter what, he's going to take his own first. And the good thing about breastfeeding is that once you have made up your mind that you are going to breastfeed, that aspect of making up your mind, the psychic, operates at the level of what we call the limbic system. That's the seat of emotion. And that is why when a woman is not happy, or she's going through a lot, or she's having difficulty physically, emotionally, all those things, successful breastfeeding becomes difficult. So the thing that is there is that the hypothalamus is part of the limbic system. Then the next thing that is very important is the suckle reflex or emptying of the breast. So if the baby is born, the woman has made up her mind, and there is a gap in knowledge that is not about the size of the mammary gland, which I told the woman yesterday that, I think it is only the Homo sapiens that have attributed sexuality to the breast of all animals that God created. The breast is to nourish the child. But unfortunately, we as humans, we have seen it as a sexual symbol or arousal and all those things. So what I'm saying is that no matter the size of the breast, it can breastfeed successfully. And what is going to calibrate the breast to come out very well, efficiently, is actually either the suckle of the baby, or if the baby is not sucking, the woman herself is emptying the breast. The more the baby suckles, and the more the breast empties, the more the milk comes. In fact, I always joke with my mothers that we can actually be in business, because when the breast milk starts coming in very well, you have enough to give your baby, and we can sell some and make money. You know. So now, the first 100 days of life is what we have always talked about in this forum. And 1,000 days of life. The first 1,000 days of life. And it takes care of the time of conception to the first 2 years of life, which is critical to the growth and development of the infant. Now, once the foundation of anything is faulty, even the scripture recognizes that what can the righteous do? If the foundation is faulty, you build on foundations that are strong, edifices that are tall and towering. But if the foundation is poor, you cannot build a tall edifice. If you try it, you know what is happening in Nigeria now. The house is going to collapse. So, what are these challenges after the infant is out and we have tried to do exclusive breastfeeding? Now, there is a difference. We also have to know that there is a difference between exclusive breastfeeding and baby friendly. Now, exclusive breastfeeding is actually breast milk alone for the first 6 months of life. And the only thing that the baby can take at that time are medications if the baby is ill. But if the baby is not ill, the baby takes only breast milk without water. Because we know that the breast itself produces the milk, and the milk actually somehow is also tailored to the gestational age of the baby. Aside from that, people have also done research to know that there is no need for you to add water. When you begin to add water to the breast milk, what happens is that the water is going to take space and the baby will not get enough nutrients. So actually, one of the problems that let me say mothers who are not attuned to what lactation does is that when the baby starts breastfeeding, the initial milk that comes out actually quenches the thirst of the baby. So those milk are actually not as dense as the later one. So if the mother puts the baby to this breast and it quenches thirst, and before it goes to take more that will now give satiety, you change the baby to this side. You quench thirst here, you quench thirst here, you quench thirst here, the baby will actually not get satisfied. And these are part of what leads to fussy babies. So the baby is crying excessively and all those things. Now, after 6 months, we know that the baby needs to now transit into some other food. A lot of mothers these days actually begin to give their babies cereal-based food before they are 6 months. And this is a very harmful or inimical practice that we need to all know. At that time, the gut itself is not mature to handle such things. And that is when we now begin to have issues of macronutrient deficiencies. Macronutrient deficiencies, which has to do with inadequate intake of protein and also essential fats. Now, Why is protein important? Protein is what helps us to produce most of the antibodies. And, we have structural protein, we have messenger proteins, and so on and so forth. Most of our antibodies, even the barrier cells and all those things, are formed from protein. So if there is no enough protein, the baby cannot make enough antibodies. And also the first line of barrier or immunity is the gut epithelial cells and all those things. They are not going to be well formed. Now, the essential fatty acids are also important. Omega-3 and omega-6 fatty acids are part of the components of the cell membrane. And if the cell membranes are not well formed, then there is going to be problem with the way, it's easy for the pathogens to invade the system. I just mentioned macronutrients. Macronutrients. What about micronutrient deficiencies? Of course, a baby who is not taking enough, whether due to is not taking enough calorie, protein, or fat, a lot of time preceding that, there are a lot of macronutrient deficiencies. Vitamin A deficiency, this weakens the immune system and increases susceptibility to infections, especially diarrhea disease and measles. Of course, the integrity of the mucosa lining is also compromised. Iron deficiency. When there is anemia, how do you want to carry oxygen? You understand it? So oxygen transport is affected, energy levels are low, and overall growth and development is compromised. Zinc deficiency. Zinc is an essential part of most second messengers and all those things. When there is deficiency in zinc, there is also a lot of problem with growth and development. Iodine is important for neurocognitive development, folic acid, and so on and so forth. Now, having said this, poor feeding practices. I've mentioned lack of exclusive breastfeeding, and also even when the woman has done exclusive breastfeeding and it's now time to win, what kind of food do you win with? If you go and begin to engage in food that you cannot sustain, which some mothers do, then it's a recipe for disaster. What do I mean by that? We should actually look at our environment to be able to choose the kind of food that we give our babies. If we are giving our babies Cerelac and all those things, can you sustain it? Can you afford it? You understand it? So those are that we should. So a lot of my babies, the babies that come to me, come because there is what I call nutritional mismanagement. This is very important. Now, the consequences of poor nutrition definitely leads to stunted growth. And when it happens in the first 100 days of life, which is 2 years, 1,000 days, why am I saying 100? Maybe if it is money, I'll be saying 1,000. You understand? So, when this happens, then, there is a saying that they say a dwarfed vision is a dwarfed destiny or purpose. Once the baby is stunted, that stunting that is evident by height, that wasting that is evident by weight, all these things actually add to making the purpose, the potential, and destiny of that child to be problematic in future. So if we want to actually ensure that our collective future is protected, is bright, and is colorful, we need to ensure that we get our children to have the right start in life. And the right start is exclusive breastfeeding and breastfeeding till the second year of life. And when the baby negotiates that he wants more, he can still continue. Thank you.
Thank you very much for taking us extensively through the very beginning of what we talk about in infant nutrition. Like I said, we must start from home. They said there's always a foundation to every building. So in building the nutritional capacity of the newborn, and as they grow, we must start from the foundation. And that foundation is breastfeeding. We will take it up from there as we invite, I think we should invite Etel Oburo to talk to us first, and then we ask the nutritionists to wrap.
Good afternoon, everyone. Good afternoon, my panelists. My name is Etel Oburo, and I'm here to talk about the challenges that we face in our profession, in our practice, about infant nutrition, growth, and immunity. Like Dr. Adeniro just said, nutrition, growth, and immunity are linked together. Babies get their nutrition from breast milk. The breast milk is gotten from their mother. And for the child to grow optimally, the child must have optimal nutrition from the breast milk. And that breast milk must come from the mother. And so they are linked, because the immunity and everything we are looking for is in the breast milk. And that's why they say exclusive breastfeeding for the first 6 months, because that breast milk at the first 6 months should be able to have all the nutrients required for that infant for that age. Then after that, complementary foods are added in order to, boost the nutrition of the infant. But we have challenges. Like I said before, I said nutrition is, immunity is tied to nutrition. And the nutrition is gotten from the mother's breast milk. If this mother that is to produce this breast milk is malnourished herself, what is the quality of the breast milk? That's one. Then if the breast milk is available, there is another thing. There are some mothers that have knowledge deficit. They don't know what exactly to do. They have the milk, but they don't have the knowledge. And that's another challenge. And you see these mothers, like he was explaining, a mother who is breastfeeding, instead of putting the baby to breast for like 30 minutes on one breast, put the baby to breastfeeding for 5 minutes, the baby takes just the 4 milk, and takes the baby to the other breast, takes the 4 milk, which is just water to quench thirst. The real milk that has the nutrient is not being taken by the infant. And so, baby is breastfeeding, but baby is not breastfeeding optimally and not getting enough nutrients. Then, there are some babies that are born. Unfortunately, they will lose their parents, their mother, at birth. But this baby has to feed. How do we cope? That's another challenge. And finding a way around it, in neonatology right now, there's what we call surrogacy in breastfeeding. The units, they have tried their best in ensuring that they bring in women who are lactating to be able to donate breast milk after screening and consent from the parents or whosoever that is there for the baby to give their consent for breast milk to be taken from another woman who is lactating for the baby. Then again, the same question. How rich too is that breast milk? That also is another thing to consider. But okay, if all is well, there are times that you might not get the donors. The baby is there, there's no mother. Okay, We have made arrangement that mothers who are lactating, who are ready, are willing, have consented to donate their breast milk are available, but now they are not available. Will this baby die? No. We have to look for another way, a substitute or an alternative for that baby. Then also, apart from that, there are some mothers, because maybe for one reason or the other, they went through the neonatal unit, and their baby was initially on scheduled feeding every 2 hourly, every 3 hourly, and they go home. They don't understand the cues, the feeding cues of the baby. They believe that the baby must be fed every 2 hourly, whether the baby is hungry or not. And so when you bring the food when the baby is not hungry, the baby does not show any interest. And they will say that, they offered baby food, baby refused, baby is not eating. But they have not taken pains. One, because of lack of knowledge, they don't understand the baby's cues when the baby is hungry and when to feed. Because when the baby is hungry and is giving all the signs that it's hungry, putting hand into the mouth, trying to, sort out where the breast is and all the others, and the mother does not understand what the baby needs. At that stage, if you give the baby will lash well on the breast and be able to get enough until satisfied. When the baby is satisfied, it is only the baby that will withdraw from the breast. So those are some other things too that you put into consideration. Then there are some behavioral patterns from babies. This one now you can't blame the mothers. These babies just decide not to suck. I'm talking from experience. I'm not talking from books. I'm talking from life experiences. Myself standing here, I use myself as an example. My first baby, as soon as it's 6 p.m., once you give him that evening bath, she sleeps off. There is nothing on earth you will do to make her feed. She will not. But as a nurse, I know that this child ought to feed through the night, but this baby will never. You try to force the nipple into his mouth, he's fighting you, pushing the nipple away. Why? I don't know. But it was a challenge, and it was a challenge that took me years to be able to sort out. Because I went to the pediatricians, and of course, what did they tell me? What was your child's birth weight? I said 2.8 at birth. Okay, what is the weight today? 4.1 kg. You say your baby is not thriving. If your baby is not thriving, baby was 2.8 at birth, now it's 4.1. The baby is thriving, I won't even give you multivites. Go home and sort out yourself. I cried. I cried as a mother because I know what I was going through. But nobody seemed to understand me. And it's still happening till tomorrow. There are some challenges like that. You are ready. The breast milk was flowing. Ready to offer the breast milk. But the baby is not ready to suck. So that's another challenge. Then there are some other challenges like a baby that has congenital anomalies. Cleft lip, cleft palate, and all the others. We all know that it's not easy as a nurse to feed those babies, whether with breast milk or any other alternative. It is not easy. So that's another challenge again that affects the child's nutrition. And also, the mother. There could be some conditions in the mother also that will make her not be able to breastfeed. Some, they will say, okay, if you cannot breastfeed, express your breast milk. But some, you can't even use the breast milk because maybe the patient is on drugs that might have impact on the baby. And so, you cannot. So, there are challenges. If I go on and on, I will continue to talk. I think my time is just 5 minutes. But, looking at it, you have information issues. You have, like Dr. Adeniro talked about, behavioral issues from the mothers. You have the problem from the babies. You have the economic problem that is all over, looking at us, slapping us on our faces. Nutrition now in Nigeria, even for me, I don't think I am feeding well as I ought to feed. Yes, and that's true. There are some things that I really crave for, but I can't buy them. And so when you are talking about nutrition, it doesn't start from when the woman is even getting pregnant. It should be preconceptional. You start educating them. what to eat so that they eat the right foods, so that the macro and the micronutrients we are talking about will all be present in the breast milk. Because if the breast milk comes and is suboptimal, definitely it will affect the nutrition of the baby and the immune system, because the immune system depends on the nutrients, the breast milk that contains the essential nutrients, for the optimal development of the immune system. I will stop here and maybe my other colleague will continue. Thank you.
Well, thank you very much for the aspect you have handled. That is the challenges that we face while doing breastfeeding. So it's not without problems, but there are always solutions to every problem. Like people would say, knowing the problem is already a solution in itself. It is when you don't even identify the problem, that is when the wahala dey. But now we can identify some of the problems that women and babies will face during breastfeeding, and then we can articulate answers to them all, so that at the end of the day, people can go home happy, not a woman coming to the clinic or meeting a health worker, returning home very sad and crying because he or she has not been well informed, or her questions have not been answered, and so she's still returning home with the anxiety she came to the clinic with. That should not be. The meeting between the mother and the health worker should be a meeting that at the end of the day, the mother will go home smiling because her worries have been addressed. Whenever we fail to make a mother happy going back home, then we have failed in our interventional approaches and methods. And I think that is part of the reason why we are here. Maybe as we continue with this discussion, people will tell us more by the time we throw it open, so that we all can be better educated from personal experiences, not theoretical experiences. Personal. Thank you very much. So on that note, we will invite the nutritionist to come and anchor the last leg of this high table discussion. Thank you.
Okay. Good afternoon now. Thanks to my colleagues for laying the foundation for us to discuss. Some of the things that I would have wanted to talk, some of them have already said it, but I will still chip in, because what we are discussing is the nutritional challenges that influence infant growth and immunity. And all of us know the category of that we call infant. Those children that are still within the first 1 year of life. They are the one that we call the infant. And we all know that the first major growth spurt occurs at what? At infant stage. So if we don't get it right, we might lose it even in the future. So, and for us to catch that growth spurt, it lies in what we are giving the infant: healthy nutrition. They've all talked about the benefit of exclusive breastfeeding. But we don't stop at exclusive breastfeeding. We call it optimal breastfeeding, which means that you're going to do exclusive breastfeeding, then you continue breastfeeding till when? The 2 years of life, or even beyond, according to the WHO standard. So, but these days, maybe when we are discussing, we can, list our observations so far. We find out that many of our mothers don't even breastfeed. Anybody that breastfeed up to 1 year, 6 months will start clapping for her that she has tried. You can see a mother that the baby will stop at 3 months, and she will be happy. At least this baby has settled me. I can go and do my business and do my work. So after the exclusive breastfeeding, you continue breastfeeding, because that's the essence of complementary feeding that will come at what? At 6 months. That food that you're introducing at 6 months is to complement what you might not be getting from the breast milk, because that breast milk will still give all the nutrients needed for both the growth and even for immunity, all the vitamin A, the iron, and all the energy giving nutrients. Breast milk will still be supplying it. But sometimes we find out that the knowledge vis-a-vis that adequate complementary feeding is not there. Our Dr. Adenira has just said, a lot about that complementary feeding. One, he was talking, I remember a patient that he brought to us few days ago. And while my colleague was, interacting with the mother of the patient towards the tail end of their discussion, she asked the mother, do you know how to prepare soya powder? And the mother said, yes, I've been preparing soya powder before. Okay, how do you do it? She said, no, tell me. No, my colleague said, just tell me how you've been doing it. Do you soak it at all? She said, yes. How many days? She said, 3 days. So that was how they concluded, and she had to, explain to her. So sometimes the knowledge is not there, and our mothers will not own up that, yes, they don't know. And even some of us that are health workers, at least some of us attend, antenatal care. Maybe because we are working in the hospital, we believe that antenatal care is focused antenatal care. It's not for us. Then let alone those that are working in the primary, or those that the mothers that visit all those peripheral hospitals. So there's a lot of gap, and is influencing on the child or infant growth and immunity. And we know that from that 6 months, if you don't get it right, that's when the issue of the stunting that Dr. Adenira was talking, the issue of underweight, the issue of wasting will begin to come. The issue of micronutrient deficiencies will begin to come. Because some of the food that the mothers may be giving, if they are not giving it appropriately, and that's why we say it has to be what? Age appropriate complementary feeding. And you take into consideration how to combine to make sure that, okay, you're getting the calories, you're getting the protein for the growth, you're getting the fats, and you talked about omega-3 fatty acid, which is part of the long chain polyunsaturated fatty acid. You're getting it both for the brain growth, both for the linear growth, both for immunity. So, and for the mothers that cannot afford, some of the homemade series and some of the fortified series that are rich in some of those, healthy nutrients. Example, the vitamin A, example, the iron, because some of the locally available series, if you don't combine well, adding the fruit or the food that will give the vitamin C, you find out that that iron will not still be available. The baby can consume it, but is not getting it. So, and that is where we talk about, making sure that the mother has the knowledge vis-a-vis complementary feeding. There was a time we were talking about 4-star diet. When you talk about the 4-star diet, you make sure that all the nutrients, number 1 star is providing the calorie, number 2 is providing the protein, 3 is still providing the protein from the animal section. Then the star 4 is providing both the vitamins and the minerals. So when there is a gap, in relation to the complementary feeding, then there's a problem. Then another thing that, maybe we need to talk about is the food safety and hygiene. Very important, because at that stage, the infant is very they are categorized as what? Vulnerable group. So if there is any problem with the way the food is being handled from the preparation to the table, it can trigger GIT issues, which the mother might, if it doesn't have the money, she will first of all go to chemist, say, give me Diastop, give me Flagyl. And if those cannot handle it, before they will go to the hospital. And those things can bring down or affect the immunity of the child. So when we are talking about, the factors that affect, or the nutritional factors that are influence, the child, infant growth and immunity, that is another one. Then another thing that we need to look at is, maybe infectious diseases or some sicknesses. It is more of a secondary malnutrition. A baby that is immunocompromised, the nutrient need and the nutrient requirement is always higher than, his or her peers. Especially maybe even a baby that is having a FTT, failure to thrive, and they are unable to even find out that the baby is having a problem. There are some babies that are not growing, and maybe because the mothers or the caregivers don't go for a medical check, don't go to hospital regularly to even do growth monitoring, they will not know that the child is growing or not even growing. So those are part of the things that are needed. Last time I was, listening to one Zoom meeting from one Indian association, MENA Medical Genetics Association. They were discussing on phytoketonuria in children. So I was just wondering, asking myself, do we even go to the extent of looking for the first baby they didn't find out on time, and they affected the child, the growth and general development? But they were able to do some, level of assessment. The second baby, they were able to pick that the baby had, that there is phytoketonuria in the family. And they were able to use some of their technologies, enzymes, and some modernized ways of handling, phytoketonuria. So maybe Dr. Adeniran will still talk about it, how prevalence in our locality, and how, because if it is glucose or lactose intolerance, we know it's very common in our own climate. But some of those amino acid issues, I don't know how prevalent they are. Then another one is the socioeconomic factors, which my colleagues have already said, poverty. Because at the end, when you finish talking, and the mothers or the caregiver don't have the money to get whatever you have, no matter how cheap they are, then there's a problem. Then lastly is marketing. So that's it's an indirect issue anyway. I was in a seminar and the presenter was talking about how we metamorphosize from 3M to 4M. 3M was more of the milk, then the malnutrition and modern. Then the 4M now is the milk, the marketing, malnutrition, and modern. So because the advent of infant formulas, the producers and the marketers, they have the money. And they are aggressively pushing their products, in the market. And what people hear about, what people see, that's what they go for. The people that are pushing for exclusive breastfeeding, the NGOs, the United Nations, that are pushing for the code of marketing breastfeeding, they don't have the money. They call them the pro code, but they don't have the money. Those that are against the code, the anti-code, are the IFM producers or manufacturers, infant foods manufacturers, and the government, because the government need the tax. They are getting money from them. But we here, we are the experts. We are the 30 code. Whatever they say, we believe. If the anti-code, if they bring their own bargain and it's okay, we accept. If the government, if they bring their own bargain and it's okay for us, we will accept it. So, but while we are accepting, we'll balance it for the health of our baby today and for the health of our, society in the future. Thank you.
We shall go ahead to take a few comments from the audience and then we summarize. So on that note, we want volunteers. We want to take about 5 volunteers that will use as background. We have different people here, people from the primary health sector, people from secondary health sector, people from private sector, and people from the tertiary health sector. We have all of you here. So we want people to give us voluntarily their experiences vis-a-vis the topic we are handling: infant nutrition, growth, immunity, and challenges. Who is giving us the first shot? Just talk to us on experiences, what you have experienced personally or what you have experienced with your patients. And 2, if you have questions you want to throw, I'm sure you can find answers in this multitude.
I'm Emeka Aboin. Well, with this kind of panel that I have discussed, I was wondering what we are coming to say again. But we must say something. Infant nutrition is very, very important, critical. And there's a lot of misinformation, and which is hampering proper infant feeding. But let me start from breastfeeding. It's a big issue, even amongst health workers. One basic challenge is even we that are the caregivers. Many of us are not convinced that a newborn, full-term newborn, can survive for 12 hours, 24 hours without feeding. Because the story is that the breast milk is not coming. It has not started coming. So we must have to give infant formula. And you are saying it's not coming. How will it come when the baby had not been put to breast or not being put to breast repeatedly? It's only when the baby is put to breast repeatedly that the milk will start coming. And the milk will start coming small, small. It will not be coming, flowing and wetting the mother at that stage. Because what is coming is colostrum, special milk that is energy dense, even when it is small. So, and you find out that by the time you introduce the baby food, the infant formula, and some people give glucose water, some people give water. All these things are not the best. And when you start giving the baby, when health workers start offering that infant formula to the baby, and they usually give the infant formula before they put the baby to breast. How can I finish a bowl of gari and you are bringing rice for me to eat again? I will only go to sleep. And before you know it, the baby has developed what we call nipple confusion. And you start saying, my milk doesn't flow. Every effort has been made. This one, that one. But it is by emptying the breast, as our boss said. It's a company, I will always say that it's a company that gives you extra from what you have taken. If the breast is a factory, is producing milk, and it gives you 100% and you take 75. The next time we give you 75 and you take 50. And before you know it, gradually the milk will dry up. And you say, my breast does not flow. There is nobody that the breast does not flow. So we, the health workers, should first and foremost understand that continuously putting the baby to breast, that early time, is what will make the milk come. Emptying the breast, and the breast will come more and come more. And breast milk is very, very fundamental. Something a baby can survive on for 6 months without water, without any other thing. You should know that that is the best. And after that, the other one is communicating our mothers on how to constitute the supplementary foods from that 6 months. Because it's not just anything. If you just make glue of pap, even when the pap is thick, there is nothing in the pap. The pap is just a vehicle. It is the other things you add into the pap that will make the food rich. You always know that 100 ml of milk is 7 kilocalories to 70 kilocalories. But thick pap is not even up to 20 to 30 calories. That means there is nothing, you can know how constituted milk is. And it just gives you 67 kilocalories. Thick pap will not even give you up to 20 kilocalories. So it's what you add. What do you add? The other thing is, information mothers do not know is that at 6 months, you don't start giving the child glue. Don't start giving the child pap. That is the time you start exposing the baby to the child to all variety of foods that you take. All variety, including, but it should be in pudding. You don't have to give the child something that is grain or something. You mash it, make it like a paste, and start giving the baby. Both gari, rice, beans. You don't wait till 7 months or 8 months. Some people just give glue for another 3 months, and the baby is 1 year before you bring the first swallow or you bring the first soup. And you'll be struggling. And you say the reason is because you do the exclusive breastfeeding. Not really. So let me not take too much time. Let another table come and talk. Thank you so much.
Thank you. That is very nice. I think he has taken us to another realm, letting us know that initiation of breast milk or breastfeeding is not as easy as we think. And actually, like I said during the opening, initiation should be at the time of delivery. You know, you don't need to wait.
Good afternoon, all. Considering what the doctor said about health workers, that sometimes health workers don't help issues of lactation. Now, I want to find out, when this woman is somebody with very flat nipple, you see, because we have noticed this, preparation of lactation starts antenatally. We tell them, please try and draw your nipple. We do that in the hospital, but we don't follow them home to know what they are doing. Now, this woman comes into the labor room, delivers her baby, and the problem with the nipple comes up. What do? We do all, in fact, you need to witness a mother with flat nipple. The child will be crying on ending. You do everything you can for the baby to grab the nipple. It becomes impossible. What do we do as health workers? So I am here to say that it's okay. I'm not saying no, but to the other side, I'm saying no, that health workers, they do their best concerning the nipple, but we cannot follow these people home. And again, sometimes you find out that it is natural. That flat nipple becomes very natural. There's nothing you can do about it. So if we see such people, when we see that the baby is losing weight, we tell them, well, the only thing, because we try to express the woman outing that is very painful, that she cannot bear it. And the baby is there suffering with hunger and lack of nutrition. What do we do as nurses?
The truth is that she said something and she didn't follow it up. Before the woman puts to birth, that is the time for intervention. So when the woman is coming to your antenatal clinic, you mark her out as a special case. Once you notice it, you mark her out as a special case. And you don't need to be giving her 3 months appointment. This is a woman that you probably need either 2 weekly appointments to see and follow her up and see what she is doing. And I know that in some places, we have taught people how to use a syringe. You know, you cut to size, which the woman can wear under her bra so that it will help her during the period of antenatal prior to delivery to see if you can bring the nipple out enough before the time of delivery. Sometimes you can even ask the husband to assist the woman to bring out the nipple. That the nipple is flat doesn't sentence that woman to the incapacitation of breastfeeding. She can still breastfeed, but we need to actually encourage her and do all we can to reverse the situation before the baby comes. Because once the baby is born, that emergency period becomes very difficult because the baby will not wait. The baby needs to eat. And if that is the time you want to try to reverse the nipple to a position where the mother can breastfeed, it becomes very difficult. And you may have to now use alternative method.
Okay, good afternoon, everyone. So I'll be speaking both from experience and practice so far. For the challenges in neonatal units back at work, you have some mothers that regardless of whatever you do, they cannot just produce that breast milk. You drink tiger nut, calm your head, do this one, whatever you do, nothing comes out. It's, in fact, you keep talking, and then if you are in FMC Asaba, prof can be rolling around that mother for where nothing. And then you have some that they are practically breast factories. In fact, it was because of one mother that we had then that made prof to go and buy a fridge. That's how we started storing breast milk. The woman will produce like there's no tomorrow. In fact, then I used to say this one is like a cow. Oh, God have mercy. She will. There are some. So I feel it's a two-way thing. There are some mothers that are very lucky to produce excess, and there are some they are begging God that, but it's me that born this child now. Why is this milk not coming out? So it's a challenge actually. Personally, with my first baby, I was producing like there's no tomorrow. With this one, we are battling. It's tug of war. From the very day I delivered till date, we are going back and forth. Okay, we'll get there one day, we'll get there one day. So I feel it's in as much as yes, breastfeeding is best for the baby, is the best milk for the baby the first 6 months. But when you have challenges like this, there's nothing you can do. You will not have to. The baby must feed, the baby must survive. And that's why formula feeds, even as much as we don't encourage it, it's not breast milk. There's nothing, you cannot copy God. God is God. It's God that created it. But it is in the similitude of breast milk. And so when you see mothers that are struggling to breastfeed, nothing is coming out. For crying out loud, as health workers, don't now say because the child, there's no breast milk, it's breast milk or nothing. So that the child will now stay there. And some mothers are very stubborn, regardless of what you advise. They will not do that surrogacy. You tell them, sorry, they will tell you that there's something, their connection, they can't feel it. They can't give their babies another milk. And it's understandable. Personally, I can't do surrogacy. With my second baby, I did not agree. Nothing like that. I started formula. It's me that born the child. So if you have a problem with it, you can go and do whatever you want to do with yourself. So in as much as we do not encourage formula in the first 6 months, but when a mother has a challenge, and unfortunately, the breast milk is not just coming. For my second baby, I was stressed, preparing for exams and all of that. I have to start formula. So there are things, like my chief said, there are things that affect that hypothalamic production and all of that. The breast milk will not just come. So definitely, there must be another solution. The child cannot be hungry. So that's my own.
Thank you. She's my Oga's daughter. She's my Oga's daughter. But I'm happy that you nailed it. While you were talking, I told your dad that we know the circumstance around the second birth. You understand it? The circumstance around the second birth. These things are not, science is fact. You understand it? The Gaussian curve shows that many more persons are in the middle and you have outliers. You understand it? The outliers are fewer. So when we are talking about, people should breastfeed, it means that many more persons should be able to do it effortlessly. It's only very few that are not going to be able to do it. You understand it? Then when Matron came up and was talking about nipple. Now nipple they take breastfeed. You understand it? Is it nipple they use in breastfeeding? We have to be very careful. Well, just hold on. What you need to breastfeed, it's actually the areola, not the nipple. Now we know that. I mean, it's ingenious what we've been able to do. That's what they call nipple correctors. They are very expensive. You understand it? Especially now we are not producing it, and we've been able to use homemade or appropriate technology using syringes to do it. And I always say it in most of the meetings. You see, people like us, even now, I still like breasts. However you look at it. So telling me, you don't need to tell me to suck my wife's breast. You understand it? Even the Bible says it. Not to talk of when it is therapeutic for my son or my daughter that is coming. You understand it? So these are effective ways of dealing with this thing. We don't need to make a mountain out of a molehill. But basically, many more women will effortlessly breastfeed their babies. Thank you.
One of the challenges I've noticed during the course of my practice in antenatal clinic is the issue of the mother getting pregnant maybe 2 months or 3 months after delivery. And then when they come like this, they will say, nurse, I don't use my hand kill the pikin wey God give me. Because they will feel that they are not supposed to continue to breastfeed that baby with the growing baby inside. Even when you encourage them to continue breastfeeding, they will still go home and their mothers at home will tell them it's not right. It will make the baby to become sick. And then what I want to ask, even when you encourage them to continue to breastfeed, for how long will they continue while there's another baby is growing in utero?
You see, in Africa, we actually we do many things without what I would call evidence or fact. I would say that you see, it's actually the failure of antenatal care. It starts from antenatal, that she actually got pregnant while she's still nursing a baby. Yes, you see, it's good to take responsibility. So, how do we deal with such situation? We know of lactational amenorrhea. If she was actually breastfeeding well, adequately, ordinarily, most women, again, I'm talking about the Gaussian curve, majority of women are not likely to enter that problem. When you investigate that kind of woman, she was not doing effective breastfeeding. You understand it? That is one. Now, the deed has been done. It has happened. The myth saying that, maybe the breast milk is going to do this way, there is nothing like that. The mother should continue breastfeeding that baby. The mother should continue breastfeeding that baby. Because the truth about it is that, you see, we are in a challenged society. If she doesn't breastfeed the baby, then what happens is that that baby can actually become malnourished. Don't forget that the definition of kwashiorkor is the disease that the new baby has. The old baby has when the new baby comes. So what happens is that is actually a setup for malnutrition. So and again, I remember that Dr. Aboyin said that, do we even believe what we are discussing? That is why we are here together to talk about evidence base. It's not myth. They will tell us, for example, our grandparents actually have a way they deal with issues. They will tell you, for example, that you should not sit inside a mortar. It's because it's unhygienic. But some of our myths are actually not founded on science. So that kind of woman should continue to breastfeed the baby. Till when? Until she delivers. It doesn't stop the baby inside from growing. It does not. You understand it? It does not. So let me tell you this. You see the amount, the quantum of oxytocin that you need for myoepithelial, this thing is not the same thing that you need for the uterus. Please. So you see, these are based on evidence. And now we are talking about, okay, we should use formula feeds and all those things. Most of us here, if they tell us to give formula feeds continuously, you become bankrupt. And don't forget that if you want to use it, you must be AFAS. How many of us can do AFAS? I think I should leave it that way.
Well, it's just to add flesh to what he has discussed. In practice, I have had contact with women that are pregnant. This is not theory. Pregnant after 2 months of delivery. Now, it even affected a medical doctor, now a professor. True life story. Had her baby, and before it was 2 months, before the baby on hand was 2 months old, she was pregnant. And guess what? She had twins this time around. Medical doctor, I'm not talking of a market woman. Medical doctor, a pediatrician. The theory that he had propounded works. That the majority will not get pregnant while they are breastfeeding effectively, but that even at that, you could be breastfeeding effectively and still get pregnant. That one is the outlier. So it happens, and we have stories, and then we have reality show on it. That woman saw when terrible, but she was able to pull through, and she brought out her twins. Those ones are also mothers now. Those twins are mothers now. So the truth of the matter is that it is a reality. And when it happens, we must support the woman to be able to cope. Very important. We must support her to cope. Beyond that, even right here in Asaba, I have monitored women who got pregnant very early, and they continue to breastfeed up to the 5th month of pregnancy. 5th month. Reality. 5th month. And in fact, at the 5th month, the woman was saying, doctor, let me continue now. I'm enjoying this thing. I can continue to breastfeed my children, my baby. Because a bird in hand, they say, is worth more than the thousands you have in the bush. You don't know what that baby that is in the womb holds for you. Will come out with one congenital anomaly that you will start weeping and crying all the days of your life. So, but this one that you have, that is perfect, why don't you make sure that this one survives? Well, God can make it possible to that other one will be perfect. Then you have 2. So there is not to throw away. And the theory and the myth about not getting pregnant early is for the survival of the mother, not for the survival of the child. It was a theory that we have in Africa to protect the woman, so that the woman can recover before the next pregnancy. Okay, that was our theory. But we also know that, yes, a woman who is breastfeeding and pregnant can continue to breastfeed without any qualms. The only caveat I have for that, is if the woman is the type that is always vomiting. There are some women, it is vomiting per second during pregnancy. Such a woman may not be advised to continue. We don't want her to die. So alternative method must be approached. But some women, when they are pregnant, you don't even know they are pregnant. They are eating anything they see on the streets. So such women should continue to breastfeed. Now, for the mother, your mother-in-law, your father-in-law, whoso-in-law that is there, who may not want you to breastfeed by way of African folklore, and you don't want to offend them, what I tell my people or those who come to my clinic is that let this pregnancy information be between you and your husband. At least the mother-in-law will not know you are pregnant until the 4th month, except if you are having abnormal pregnancy symptoms. If you are not having abnormal pregnancy symptoms, emesis and all that, your mother-in-law will not know that you are pregnant, except you tell her. So you can just continue breastfeeding. And by the time your pregnancy is beginning to show, which is 4 to 5 months, and your mother says, it's like this, your stomach is not going there. Say, Mama, now so I see him. Now so I see him. I go do ultrasound to find out why it is not coming down. Meanwhile, you already know that you are pregnant. Tell Mama that is how I see it. So you can actually continue to breastfeed in reality, except if you don't want to. If you want to, you can breastfeed and nobody will hinder you. Hide the story from your mother-in-law and your father-in-law and your whosoever. Just let it be between you and your husband for the survivor of the child that you have on hand, and also, by extension, the one in the womb. Thank you.
A woman who puts to bed and have triplets and is actually not lactating well, how long do you encourage her to breastfeed? And can you also encourage her on a BMS, as in breast milk substitute?
She has brought up the difficult one. We don't like thinking the normal one. She has triplets. You are going to be a very wonderful examiner. You understand it? Now, the truth about it is that, Matron will come up and still talk. The truth about it is that, common things occur commonly. That is one. Two, in terms of breastfeeding multiple births, yes, there are usually challenges. A lot of time, the breast milk may still be able to take care. But when you say 3, you've given that, even you yourself, you have the, first and foremost, how many breasts do you have? So at a point in time, actually, if it's a twin gestation, for me, it's straightforward. But you have brought this extraneous thing to it. You are talking about the 3rd one. Maybe you talk about the 4th one too. And that is a bit out of the ordinary. And definitely you may need help and assistance in this. Matron.
I want to use the example of Era Specialist Hospital some years back. A woman had quadruplets and people were wondering. That was when exclusive breastfeeding came initially, when all hospitals were clamoring, to make sure that their hospital key into it. And Era said, this woman, they will use her, she must breastfeed these babies and let the world know that you can achieve it. The woman was kept in the hospital for that 4 months. Yes, they were supporting. If you are a mother and you have breastfed exclusively, you will know that one, even my daughter, observe that each time I breastfeed, after breastfeeding, I request for water. Yes, if you support this woman adequately, give fluids. The breast milk is like a tap. When you open it, it continues to flow until you shut it. If you open a tap and you don't shut it, it will continue to run. But if you shut it, it will shut. The brain is there. It's whatever signal that goes to the brain that you get as feedback. And so if you continue to breastfeed and there is good support, nutrition, fluids, and the others. When we say support, I mean support. This woman does not work. All she does, the work she had at this period is breastfeeding these babies. There are people there to do every other thing. They make her comfortable, make sure that the fluids are available to her. And she breastfed for 4 months. Those babies were used, I think they put them in an almanac and sent over some hospitals for people to know that a woman had quadruplets and was able to breastfeed for 4 months. Thank you.
talking about my life experience, very, very brief, and then I'll go to my own clinical experience. Okay, one of my sons then, I was just like, I want to do exclusive breastfeeding. I was feeding. However, the baby wasn't adding any weight. Knowing that I know that my first child, my second son, I did the breastfeeding. Until I met a colleague and she screamed and said, Rachel, what's happening? Your son is 3 months old and he's not looking chubby like the other kids. So in all, I went to weigh the child and realized that I was not expressing as in optimally. I thought I was actually breastfeeding the child. Every time he asked for birth, the milk wasn't flowing as much. So then it now occurred to me that my breast milk as at that time was not enough. I have to now go into BMS feeding. So ever since then, when I see some mothers that will come to me to FMC outside the hospital, and I notice that the child isn't growing the way they should, they will tell me, breastfeeding, that I give both day and night, and I weigh the child's weight. It's not even what commensurate to the age of the child. Immediately, I don't waste time. I will counsel her and tell her to drink enough water. She will tell me, yes, I do. Tiger nuts, yes, I do. Soya milk, yes, I do. So what else? Do you sleep well? Do you quarrel with your husband? Do you do this? She will tell me, I've done everything, but yet the breast milk isn't flowing. So for such woman, you don't waste time. You just have to go for the alternative. Okay? That's what I've been doing. And after a month, they will come back to me, Dr. Rachel, look at your baby. The baby is doing well. The baby is now fine. Chubby, because I know that a child that eats well, irrespective of breast milk, formula milk, is a healthy child. The child will not be immunocompromised. The child will be able to fight infections. So in all, I'm just saying that as we go back to our homes, our hospital, you don't just say it must be breast milk. Breast milk is good. We are actually promoting breast milk. But don't just say because you have to do exclusive breastfeeding, you must do it. You must do surrogate. They are all good, but we must look for those few ones that need assistance. That's what I do. And for the one that cannot afford it, just like my chief said, AFAS, affordability, feasibility, and all that, I go for the lower ones. Like, I try to encourage them, like, you just have to talk to your family members. Aptamil is good. I use Aptamil also. And my babies that use it, they are all chubby. I have some of their pictures. They are doing very, very well. All right, thank you.
Dr. Onwuli, thank you for your thoughts. But I still want to say as your teacher that there are some things that you said, and I want to ask. I don't know whether most of our women who take tiger nut become tigers or tigress. Is tiger nut a secretagogue, a lactogogue? I think because I really don't, because there was a time it was palm wine. Palm wine was the craze and the rave. There was a time it was pap. You understand? But I think the critical thing is actually that the woman should be well hydrated. It's the water. It's not the content. It's the water. The woman should be hydrated. The woman should be supported. The woman should be happy. You can't, when Dr. Okebu was talking, that second birth had a lot of things around it. You know, the truth about it is that nature has a way it takes its toll on us. If you don't sleep well, you cannot perform well. You understand it? And I also want us to know that, you see, you know, she said something that, okay, maybe when she now wants to use breast milk, in fact, I don't want to call, please don't call it breast milk substitute. There is, and I've told you people, there is nothing like breast milk substitute. There are formulas. There is no substitute to breast milk. but there are formulas that wants to look like breast milk. So if you are not saying that if they cannot afford the premium, they should go below it, then please let us be very careful. You understand it? Because at the end of the day, we are going to get ourselves into trouble. Another thing that we have not mentioned is the challenge, although my chief mentioned it, the nipple confusion, is the fact that when you want to, the vehicle you are likely to want to use for these formulas are feeding bottle. They have their own challenges. So these things are protein. I think it's been nice interacting with you people. You are beautiful audiences. You people have shared your experience. You have answered questions, and it's very natural. I want to invite Madam Chineye to come and talk to us. Thank you. Please clap for yourself for the wonderful interaction. Clap for her too.
Good afternoon, everyone. And then thank you again for this wonderful section. So, in all we have said today, I want to ask one simple question. Do we have challenges with breastfeeding? Yes or no? How enormous are these challenges? You've said so many things, from protein deficiency, iron deficiency, zinc deficiency, feeding practices. We've talked about malnourished mothers. We've talked about the lack of knowledge on how to breastfeed. We've talked about babies that lose their mothers at birth. We've talked about multiple births. In all this, there is just one thing I have to say. And that is why we are here today, to talk about these awesome products. What makes this product is the fact that it is the closest infant formula you can get to breast milk. I'm not capping. I'm not saying it because I want you to recommend Aptamil, but I'm saying it because I have my facts. I'm saying it because there are studies that have shown it, that Aptamil is the closest infant formula to breast milk, because it mimics exactly the human milk oligosaccharide that is found in breast milk as short chain galactose oligosaccharide, long chain fructose oligosaccharide in the ratio 90:10 to mimic exactly what? Breast milk. Apart from that, for the importance of protein, what we have in Aptamil, whey to casein, 60:40 to mimic exactly what? Breast milk, for what? Easy digestibility. You will not see that in any infant formula. Now, going forward, we've also talked about Dr. Adeniran macronutrients, where he talked about deficiencies of vitamins. If you pick up this flyer, I want everybody to pick up this flyer, please. Everybody has one of these flyers. I want us to look at these flyers very closely. You see the nutritional information on it. If you compare the nutritional information of what we have as regards iron, the DHA and ARA qualities or quantity, you find out that Aptamil has the highest as compared to the competitor brands. Then for the nutritional information concerning the macronutrients, you also find out that Aptamil has stood out in terms of the amount of vitamins that is contained in the product, not to just mention including the iron and zinc. And I want to leave this back to us right now. As healthcare professionals, you have faced with challenges for a mother who cannot adequately breastfeed. And each time I come to you to have a chat with a healthcare professional, the first thing that will always come out from my mouth is how we have put in 50 years of research on breast milk. That is the best you can get for any infant formula organization. No other organization has been able to break even in our science and research like Danone has. And that is to tell you that we are key on immunity. And that is to tell you that in the first 1,000 days of life, we want every child or every infant that is not adequately breastfed to not miss out on anything nutritionally, especially in this first 1,000 days of life, because it can make or mar the child. With this, I want to leave you with a question. Would you rather, as healthcare professionals, I said healthcare professionals, recommend an infant formula that is below the standard where the need arises? Or will you rather give the one that is closest to breast milk? As you take this question, I say thank you so much and have a wonderful day.